Thank you, Dr. Cheryl Hout, for presenting on study design, subject selection, inclusion, exclusion, randomization, and control of confounders. So you can get started.
Thank you. So welcome everybody, and thank you for joining. I'm very happy to give this talk, and what I like to do, first of all, I really like it to be interactive, so please ask questions if you have them. And as you may have heard, I can't see the control panel, so I can't see if you text questions. So really just break in and ask. We're a small group, so that's fine. And so what I'd like to do is go through this. This is obviously a very, very important topic, and it's a large topic, difficult to get very deep into it in an hour, but I think you'll get a very good overview. And I used real-time examples from a randomized controlled trial that I ran that we finished last year and are currently analyzing the data from, because I think my experience with designing this study from beginning, carrying it out over 3 years, and all of the pitfalls that we encountered during it sheds a lot of light about all of these issues. So let's get started. So I say it right off. The subject selection is probably the most critical decision you make in clinical research. You can spend a lot of time designing the methods, etc., but you have to focus the most on what is the population that you're studying. And this is not trivial. You know, you come out by thinking, okay, well, whatever it is that's your area, I'm just going to take a representative population and apply this research question to them. But as you get more and more involved with this, you will see how truly critical this is. And not only critical, but there are factors that are out of your control, that, such as finding the subject, that are completely dependent on this and can really make or break your study. So the role of inclusion and exclusion criteria is to ensure that the subject population has the attributes that will make it possible to accomplish the purpose of the research. If you design the perfect study but you can't do it, you've gotten nowhere. So we're going to talk a lot about inclusion and exclusion and what goes into that. Why is subject selection so important? Many, many reasons. Let's start with talking about validity. And validity is what drives us in our study design. And there's two important types of validity, internal and external validity. So what we consider internal validity to be is the truth within the study. So it's the degree of confidence that the causal conclusion of the study is true, that the independent variable that you're investigating produced the outcome. And it applies only to the study population. So basically, if you have a high degree of internal validity, you can be confident that the results of your study really reflect what it is that you were trying to prove in this study. And again, this applies only to the study population. So if you haven't chosen your population appropriately, you have sacrificed internal validity. And then there's external validity, which is the truth beyond the study. And that's the generalizability of the study findings to other populations. And there is a dynamic tension between internal validity and external validity. And why I say that is the more homogeneous your group, the higher your internal validity is going to be, because the internal validity increases as you have a more pure sample and a more perfect study group. But of course, that will likely make it less generalizable to the overall population. And this is very important in terms of what is the importance of your study. Is your study going to show significance but only for a very small subset? Or is it generalizable? And for many of you who are currently training and likely to remain in, for example, tertiary care centers and epilepsy, you're seeing a specific population about whom the results of studies that you do with them may not be generalizable to the population at large. So you always have to think about what's more important to you, what research question, how does the research question relate to these internal and external validity issues? And when you write your papers, that has to be made very clear. If you recognize that you only studied a subset, then you have to point out in the limitation that this may not be generalized to other populations. So subject selection greatly affects validity of the study. So what are threats to validity? We have subject selection-based threats and non-subject selection-based threats. And understanding all of this is difficult. Sometimes you need a lot of examples. But this is, again, when you're designing a study, and I think many of you at this point in the year have already been involved in research, and hopefully you'll continue to be involved, the more time you put into the early phase of evaluating your subject selection, reducing bias, designing the study to improve validity, the better you are. Because fixing things later is very, very difficult from every point of view. And I'll give you some examples of that later. So if you have chosen your subjects correctly, so bias is a systematic error that produces results or conclusions that differ systematically from the truth. I keep using that word systematic, and it's very important because there are random errors, but study designs account for that. But if you have a bias, that is a systematic error. And that means you needed to fix this in your study design portion, because once you start the study, you will likely not pick this up, and it's going to carry through the whole study. These biases are not anything that's likely to be picked up during the study. It's sort of built into the fabric of your study design. So we're going to talk more about systematic errors. And the other subject selection-based threat to validity is confounding. And I'm going to come to what that is in a few minutes. And then there are non-subject selection-based threats to validity. And the main one is chance. So we all know that certain things will happen by chance, and they're not significant. And of course, if you have powered your study correctly, you should not produce a result that's significant by chance. That's the whole way that we use power calculations. But it is still theoretically possible, because we can never, we never power a study up to 100% chance of having no accidental finding that was related to chance. So you have to, and of course your statisticians will work with you on that, and everybody knows that this is a very critical part of planning a study, powering it correctly. So the second topic here of non-subject selection-based threats of validity is not that common, as long as you've done a rigorous evaluation in powering your study. But subject selection-based threats to validity are actually very common, and it's probably a reason why many studies don't show the results that have been anticipated. So, talk more about bias. The bias is a systematic error in the way we either select patients, measure outcomes, or analyze data, and this will lead to results that are inaccurate. As I said before, this is not something that is typically picked up during a study. It's often an error that was built into the way you designed it. And so you do the study, you get results, and those results are inaccurate. So what are different types of bias? selection bias is a big one. If participants and non-participants are systematically different, or if the allocation of subjects to treatment groups produces samples that are systematically different. And so we'll talk more about it, but obviously for the second part of that, for the allocation of subjects to treatment groups, that is where randomization is your greatest friend, right? Because we believe that if you randomly assign subjects to different treatment groups, then you are very, very unlikely to have systematic differences. However, and I think this is a reality that you need to be aware of, the days of true randomized controlled trials are, I think, I don't want to say numbered, but it's more and more difficult to do this in epilepsy, and I presume that's what most of you are staying in. And there's a lot of reasons for that. And so one of the big new approaches are pragmatic trials. I assume that you've heard about pragmatic trials. In Europe, there have been some very large pragmatic epilepsy studies. And in those studies, it's not true randomization, but it's there is some input about desire to be in a particular treatment, or the doctor has a input about allocating treatment. And that actually does not address this type of bias. So you have to be very careful about that. You know, if you're dealing with a pragmatic study, the question is, well, did the doctor purposely put the person into this arm because of something individual about them? And if that's the case, they're likely to have kept doing that for all the subjects they randomized, and that will produce selection bias. Coming to the first part of this, if participants and non-participants are systematically different, that introduces a very significant selection bias. And that's hard to fix. So when we come to the study I'm going to be talking to you about, which I'll introduce to you now, I ran a study of stress reduction as add-on therapy in epilepsy. This was a randomized controlled trial with an active arm of smartphone-based progressive muscle relaxation and a sham arm of a focused attention, but not a relaxation. We did this at 3 sites, my site, my co-PI, Dr. Privatera at Cincinnati, and we did it at UCSF. And so right away you could see where in a behavioral study, those who choose not to participate are likely in some way related to the outcome, in the sense that people who maybe believe that a behavioral treatment works are more likely to sign up for a study, and the non-participants may be people for whom this wouldn't work anyway because they don't believe in it, they wouldn't do it, they wouldn't practice it, etc. So whatever outcome we have, we need to consider the selection bias. And going back to the previous slide, what would happen in a setting like that is there may be a lot of internal validity in the study. We picked good people and we did it very rigorously, etc. But it may not be externally valid if the people for whom this wouldn't work didn't come into the study anyway. So this is really where you have to think a lot about how you're designing your study, and recognize that who participates and who doesn't is largely out of your hands. You know, you can only recruit people who agree to be in your study, but you have to think about the impact of who is not participating and how is that affecting your results. So that's selection bias. Then there's measurement bias. The outcome measure is inaccurate, and that is something, especially if you're dealing with a measurement tool, different instruments. If they're set wrong, if you've got the wrong key for coding it, etc. These are, that kind of bias is really should not happen. if you've been very, very careful and very rigorous, you shouldn't have measurement bias in your study, and that's impossible to fix because again, you can't go back and undo how things were measured. If there's, again, I mean, this happens in a lab. If an assay is being done incorrectly, you can't fix that. And so that's, I think, something that doesn't happen a lot if you're very careful, but it is something that must be kept in mind. And then there's analysis bias. If you have not proceeded with the correct analysis plan, if how you're analyzing the data doesn't match the nature of the data, or if, for example, data is normally distributed and you are choosing the wrong non-parametric tests, etc. So these two, measurement bias and analysis bias, really shouldn't happen. Should be fixed and recognized and fixed before you start the study. Selection bias is challenging, I can tell you that. And then confounding, and it's a little complicated to sometimes really understand confounding, and I urge you to look up examples of this and read quite a few examples so you get the idea. So confounding occurs when an extraneous variable, called EV here, systematically varies when the independent variable IV varies. So these two variables have a systematic relationship. And the EV, which is the variable other than the independent variable, affects the dependent variable. So there's two relationships here. The EV and the IV are related. When the IV varies, the EV varies with it. And the EV has an independent effect on the DV. And so when you have confounding, effects on the dependent variable, which is obviously what you're measuring, may be attributed to the IV, but instead are actually related to the EV and are not recognized because you're not measuring the EV. You haven't accounted for it. So the worst part about this really is that the confounding variables are not in the causal pathway being evaluated, yet they are exerting an effect on the dependent variable. So in other words, confounding is the distortion of the effect of one risk factor by the presence of another. And I'm going to give you an example from the SMILE study. So this is the introduction to the SMILE study. I've already mentioned it. We use smartphone diaries that you see as an example on the screen here. We had patients entering numerous variables every day, including all data related to seizure precipitants, mood, stress, etc., medication adherence, menstruation, and all seizures. And after randomization, patients were given recordings on the smartphone to practice. So let's look at the various types of bias and confounding in that study. So I've already talked about the selection bias. Let's say that the study demonstrates efficacy of stress reduction in epilepsy. Well, one potential selection bias is that subjects who agreed to participate in a behavioral study are likely different from those who don't. So in that case, the findings lack generalizability. That's fine. I can't fix that. What I can do is acknowledge it. So as we write the paper, we're going to have to point out that it is likely that the people who agreed to come into the study have certain characteristics that those who didn't will lack, and those characteristics may impact on the outcome. So again, we can't make believe that you can avoid all selection bias because you can't. You just have to recognize it, acknowledge it, and deal with it. And at the end of the day, hopefully, when we show that stress reduction was successful, we will say, okay, it may be that it's only for people who have a tendency towards wanting to do a behavioral study. That's fine. I don't have to say that it applies to the whole population of epilepsy. I just have to acknowledge that fact. Now, how about confounding? Let's say that we do all of this and it doesn't demonstrate efficacy, right? So my results were negative. But we didn't account for depression as a confounder. So if let's think about this. We go back to here. So the extraneous variable, meaning the depression, systematically varies when the independent variable varies. So what we're saying is that in this case, if seizures are our outcome and stress is the independent variable, what I haven't accounted for is the relationship between depression and stress. And it could be that depression was preventing the changes in stress from improving the seizure frequency. And had I accounted for that, I may have excluded patients with depression. We may have treated patients with depression separately. Or, as you'll come to see, we may have considered stratifying based on depression levels. So we can deal with confounding. You have to recognize it. Okay, so we're going to talk more about that. That's an example of how a confounding variable, if not recognized, therefore not accounted for, can really ruin your study. So how do we control for this? Randomization will account for a lot of selection bias, certainly the bias of allocating patients to treatment arm versus the control arm. And so that is, considered the gold standard approach to reduce selection bias. Now, it may or may not be feasible, and I've already mentioned this alternate pragmatic design where it's a form of a randomized trial, but it's not completely, there are some potential elements that go into the allocation which can introduce selection bias. Now, how do we control for confounding? So one very good way is to match for a confounding variable in the group. That's a case control design. And so that way, taking that same example of depression in this MILE study, we have a patient who we could have assess everybody's level of baseline depression on, let's say, the BDI-2 or some similar instrument, and then match people in the active versus the sham group based on their scores. And so you could see where that would control for depression as a confounder. A very, very nice approach, which is being used a lot, is stratified randomization, in which strata are constructed based on factors that may influence prognosis or treatment responsiveness. And a randomization scheme is performed separately within each stratum. So, for example, using the same example, I give everybody the BDI, and you based on your score, you fall into, no evidence of depression, mild, or moderate. Let's say that. And so I might stratify into 3 strata. If they came out severe, we would likely exclude them, but we might have 3 strata based on that depression. And so ultimately, you're only comparing people within their strata, right? So the people with no depression, we would look at those in the treatment arm versus the sham arm, etc. So what's great about that is it fully controls for that confounder. What's challenging about that is you need a lot of subjects, right? Because instead of, when you power your study, if you're just looking at 2 groups, you can, you'll need a certain study number, but if you have now stratified, you're essentially looking at 6 groups if you have 3 strata, for example. So it's difficult if you're not dealing with a very large study to do stratified randomization. One other very important point about controlling for confounding in these approaches is that you may control for one confounder, but if there's but you can't do this for multiple confounders, right? You can't stratify randomization into 10 different strata, based on 2 or 3 confounders. So you are limited. You have to try as much as possible to deal with potential confounders when you actually select the subjects. But it is very common to use one of these 2 strategies to deal with a significant potential confounder. Age is another example. Moving on to inclusion and exclusion criteria. The general principles are you can be narrow or you can be broad, right? Maybe somewhere in between. But generally speaking, you have these 2 different approaches. So what are the pros and cons of each? If you have narrow inclusion criteria, you will have increased internal validity. So what you're talking about is a homogeneous group. They're likely, obviously, similar to each other. And so if your treatment is effective, you're very much more likely to be able to demonstrate it. Whereas we know when there's a very heterogeneous group, you may very well miss a treatment effect because the population of people for whom it was appropriate is smaller. So narrow inclusion criteria increases internal validity, but it decreases generalizability, which I've talked about before. It also poses a recruitment challenge, and we can be as pure as we want, but at the end of the day, if you can't recruit subjects, your research is going nowhere. So again, there's a very, very important balance between these 2 approaches. You need to be able to recruit subjects. You want to have as homogeneous a group as possible for most studies, but you also don't want to make it so narrow that your results are just simply irrelevant to the majority of people who have that disorder. On the other hand, when you have broad inclusion criteria, it's much easier to recruit. It increases your generalizability because you're likely to be representing a much more, a much more heterogeneous population. But it increases the internal validity, and you may actually not even show an effect because of the heterogeneity. Many of our treatments are effective in some groups and not others, some subsets and not others. And so you can dilute that by being too broadly inclusive. So just remember, narrow has an increased internal but decreased external, and the converse is true for broad. Now, what are we mandated to do in clinical research? This is related to the protection of human subjects and subject selection. Subjects are to be representative of the population required for study. Subjects are to belong to a group that is likely to benefit from the results of the research. And vulnerable subjects may participate only when special considerations have been met. So these are the rules that govern, before we get into any more details, we have to respect these protections for any study that we do. And obviously, I'm sure you would all be very cognizant of that. Now, who are vulnerable subjects? This is tricky, and there's some studies where this becomes very, very difficult. If you can't provide informed consent, so if you have an altered consciousness, if you have mental retardation, that's a vulnerable subject. How do you do research in vulnerable subjects? It's complicated. If any of you have tried to do this, it's very complicated. And then also circumstances which imply coercion, intimidation, or exploitation. So I don't know if you have filled out, IRB applications in your institutions, but if you want to be recruiting medical students, for example, that's a hurdle you have to overcome. It doesn't, you will be questioned about that on the application. Doesn't mean you can't do it, but there's a lot of attention paid to vulnerable subjects. Obviously, a lot of these protections stem from some great research wrongs that have been done in the past. I'm sure you are already familiar with that. And so prisoners are a vulnerable population. So what are typical inclusion criteria? So age. You really have to start with age because that's the most common form of, it's honestly like the first thing you ask when you're thinking of whether someone is eligible for a study. Well, what's the age range? Is this including kids? Does it include the elderly, etc.? You have to give a lot of thought about age. And depending on what kind of study you're doing, for example, NIH, if you're excluding pediatrics, you have to have a very good reason why, etc. Now, the diagnosis. Let's take an epilepsy study, right? The SMILE study. I like to give examples from an actual study. So we were recruiting both internally and also people referred. So, I went around, I publicized it around New York, and colleagues would send their patients. But I didn't make the diagnosis. We didn't do that here at Montefiore. I don't have epilepsy monitoring reports, etc. Can I, how do I deal with that? And of course you do. You make a clear plan to deal with it. But the point is you have to think about it. You can't just say, I will recruit patients with intractable epilepsy. You have to say, this is how, based on these criteria, they've been, treated by an epileptologist, and I reviewed the notes, etc. Whatever your criteria are, you have to have that listed. And whether or not you require a medical record review for external subjects will make a big difference to you in terms of both validity and also just feasibility. So, it's very important in an epilepsy study to make sure that you're treating patients with epilepsy, to exclude patients, for example, with non-epileptic seizures, etc., unless that's the study you're doing. So these things must be considered. And then intellectual level, again, in epilepsy can be very challenging. If a specific level is required, how will this be assessed? If you think about all your comers in an epilepsy clinic, there's going to be a very big range. So what's the minimum required to bring someone into one of your studies? Emotional and psychological factors, they're going to be there. Are they potentially going to confound your results? Do you have to assess it and account for this? Now, RCTs may have a separate set of inclusion criteria following the baseline phase. So it's very common. You have a run-in period. You're keeping a diary, for example, writing down your seizures. And then if you've had enough seizures, then there's another, the next level of inclusion criteria is you have to have had X number of seizures to then be randomized. Or you have to have been compliant with X or Y. So when you're writing inclusion criteria, if there is an intervention, you have to consider, is there a second set once they have finished a baseline phase. And then the exclusion criteria are characteristics which disqualify prospective subjects. And that may be, of course, there's an enormous amount of things to think about, but it may be prior or current treatments. These are very common. Now remember, we're not going to list age again here because that was in the inclusion criteria, right? You don't want to be doubling everything. So you could, age, for example, would typically be in the inclusion and not be listed as an exclusion, but you theoretically could do that. You could say everyone's, you're excluded if you're above 65, otherwise everyone's included. So it's a little arbitrary where you put certain things. But prior or current treatments are a very common exclusion, comorbid conditions, and of course, certain medical conditions, progressive neurologic conditions is a very common exclusion in epilepsy studies. And then, as I've already mentioned, certain degrees of depression or anxiety may exclude you. And I'm going to give you some specifics in a moment. Now, abnormal test results. These are often applied to information obtained after the initial consent is signed, right? So you can't start testing somebody until they've consented. So they've consented, now they're enrolled in your study. but then you see these criteria, you get back to labs, you get back to EKG, and they don't fit. You don't want them to then drop out of your study. You don't want to show those kind of numbers that you're losing patients to your study. So the way you design this is that you make it clear a person is excluded if any of these things come back, even if I don't know that result until next week. And so that they're what we would typically call a screen failure, but they didn't terminate the study. You know, they're not a dropout from your study. And these are very important distinctions, because when you write a paper and you want to say how many people dropped out, you don't want to include people who, you know, had abnormal LFTs and they never got into your study. Now remember, exclusion criteria differ from termination or exit criteria. That's different. Exclusion is you're not getting into the study. Termination or exit criteria are you're in the study and you're exiting. So if someone has abnormal LFTs, when I try to recruit them and they never made it in, they didn't exit. And that's what I was just saying to you. Those are different. People who exit a study have to be reported and have to be explained why. People who fail to screen in, you don't have to account for that later. And so what are termination or exit criteria? It's usually a worsening medical condition or non-compliance with the study protocol. So in epilepsy, you know, a very common one would be that the seizures got worse. Maybe they had a first convulsion when they hadn't had one before, that type of thing. So every study will have its own, and you have to have that built in for any trial. So here's the sample inclusion criteria for the small study that I've talked to you about. We did 18 and above. Well, why? Just didn't want to deal with what possible differences kids versus adults. So, you know, a lot of studies will do 18 and above. The trick here that I'll share with you is that 18 to 21 is pediatric in our institution. So you're inclusive of pediatrics. You're not excluding pediatrics, but from 18 they can sign consent. We did English speaking, and you have to then explain why you're excluding Spanish speakers, for example. Wanted partial epilepsy consistent with ILE criteria. We had a number of seizures per month, and I will tell you that we changed this. And every time you change your protocol, you have to put in an IRB amendment. So it's the biggest pain in the neck to have to change protocols once it's running, yet you will likely have to do it. You know, the specific criteria aren't so important, but just this would be typical. We required a 6th grade reading level as screened by a RAT administration. And what's very typical in epilepsy studies are a stable dose of antiepileptic for 30 days, etc. What I wanted to show you are the exclusion criteria that we changed during the study. And this was largely because of difficulties with recruitment and some hard realities. So we started out, everything that's on here was our exclusion criteria when we started, and the things in red were all amended. We started out with concurrent VNS use. We were going to screen out everybody who used VNS because that was something we couldn't control, you know, the use of the magnet. And we screened out some subjects that were really good potential subjects. And later, when we got into recruitment problems, we said, you know what? Why can't we have a VNS? We could just have them not use their magnet. So that's what we did. Suicide was a tough one. We went very strict to begin with. So remember, you can consider these are narrow inclusion and exclusion criteria. Anybody who had ever even dreamed of suicide was excluded. And very surprisingly, here at Montefiore, like out of our first 10 subjects, we were losing like half of them to endorsing some suicidality, not active and not actual suicidal attempts, but some thoughts about, would I be better off dead, or that kind of a thing. So we met with psychologists and said, do we really need to exclude those? And then we went back in and relaxed those criteria. So this is just realities. You have to be able to recruit, and if you set yourself up too narrow, you may have to change that. And then another one was at the bottom there, intermittent use of benzos as rescue meds. We ended up having to amend that. So the point is, you try to do your best when you design the study, you are going to encounter things that you didn't recognize. This is for any type of study, an interventional study like this one, a prospective cohort study, even a retrospective study. When you start out, you cannot recognize all of the pitfalls. You do your best to design it to reduce bias and confounding. You, if possible, can do a pilot study. That's always very helpful. If you're giving a questionnaire, give it to a few people as a pilot. If you're extracting medical data, do a few and see what did you miss, how feasible was it, and then redesign. That's a very, very good strategy. Pilot something and then readdress it. What's the reality? Recruitment will be lower and slower than you predict, almost for everything. Be prepared to adjust your inclusion-exclusion criteria to meet recruitment needs. And each time, it's an IRB amendment. Can't cut corners with it, can't get away with it. Here's a case in point, EPGP, the Epilepsy Phenome Genome Study. This is a huge, huge study, maybe the largest NIH study in genetics of epilepsy. And we were one of many centers that participated. And so the initial inclusion was sibling pairs with epilepsy. So it's a pretty narrow group. They felt that this would give you the best chance of identifying genetic markers of epilepsy. They powered the study from projections from the family study of epilepsy, but in retrospect, that did not represent population-based prevalence. And what ended up happening was that everybody in tertiary care centers, which was where the family study of epilepsy was done at Columbia, everyone immediately recruited all their tertiary care center patients, but then we were hoping to get population-based patients, and those were just much fewer than had been projected. So after 2 years, and this is again a very highly funded study, after 2 years they added parent-child pairs instead of just siblings. In year 4, they accepted data from the proband only with medical records from the sibling or a parent. So they only got the genetics, they only did a blood draw on one of the people in the pair. And throughout the whole time, they added more recruitment sites. And every time we added something, of course, it all had to go through the IRB. So this happens. It's a reality. Can't stress too much about it. You just have to accept it. So, and we've already talked about randomization. Just to remind you, randomization reduces the chance that participants are assigned differently to treatment groups in a systematic way. It reduces the chance that a confounding variable accounts for the observed outcome. It does not address external validity, and if you can do random sampling, so you take a population and sample randomly by phone calls, etc., but that really takes a very typically a very large study that can do that. That's a way to improve generalizability. And here's another sort of real-life example. I don't know if you have heard of the ERSET trial. This is a trial on early randomized surgical epilepsy. So they took patients who had failed, I think it was your second drug, and they got randomized either to surgery or continue medical treatment with third, fourth drug, etc. And it was a great idea. It was an important thing to see whether people do better if they get surgery earlier. But if you hadn't truly randomized, right, if it was pragmatic, you can recognize that there would be a lot of bias in those people who wanted early surgery versus medical. That's potential bias. So it wasn't done as a pragmatic design, which was initially discussed. Just let the doctor and patient make that decision. But the recognition that that could introduce a lot of bias. So they've made this as a true randomized trial. And you know what happened? They couldn't recruit because people did not want to be randomly allocated to surgery. It just felt too big, too scary, etc., to feel like they were going to have surgery from the flip of a coin, to quote one patient who I tried to send into the study. So this study was terminated early, and this is a big, this is a big deal in epilepsy because it had been a very, very highly funded study from the NIH. In the end, even with a small group, they were able to show significance, which is very, very good. But nobody recognized that that it couldn't be truly randomized. So even though we consider randomization, the gold standard, it may or may not be feasible. So in randomized trials, recruitment may be affected, as I was just saying. Certain subjects want active treatment, not placebo, in randomized clinical trials, and subjects don't want to be treatment allocated by chance, as we saw in the ERSET trial. And then finally, maintaining randomness in assignments is challenging. Patients are always trying, if they're in a randomized trial where they're getting either active or a placebo or a sham, they're always trying to figure out which arm they're in. And the doctors are probably trying that also, the researchers. And for example, in a pill type of, in a pharma trial where you're just taking a pill, you may not recognize the difference. So an example is we were just been doing these Epidiolex studies, which is the cannabidiol extract, and people in both groups are getting tremendous diarrhea because they made sure that with the placebo they used the same sesame oil that they used in the cannabidiol arm. So whereas if only the cannabidiol got diarrhea, we would figure it out, right? So I mean, nobody was supposed to get diarrhea, but but the point is that the integrity of the blinding has been maintained. So these are challenges. We certainly faced this very much in the SMILE study. Patients who are not in the stress reduction arm, we were concerned that they would figure it out. So as I said, it's a lot of information that I talked to you about today, but I think it's a good grounding in it. Remember, subject selection criteria and methods are critical for study success. Bias and confounding challenge study validity. And you have to think about internal validity and external validity. Start working with a statistician in the planning phase whenever possible. And intervention studies should be randomized whenever possible. And again, the real life lesson, be prepared to reconsider your inclusion-exclusion criteria as necessary. So that is it. I'm sorry we didn't have extra time for questions due to these technical issues, but I can stay on if anybody has questions. And thank you and good luck to all of you.